My goal with this video is for you to finally get down ACLS, and I hope that you'll learn something new and something that sticks with you from this video. Starting off our ACLS algorithm, looking at ACLS algorithm for the adult patient who is in cardiac arrest. So let's picture this scene. You show up as EMS, you go to a patient, they're unresponsive, they cannot breathe, and they have no pulse. They're in cardiac arrest. What do? The first thing we do is start CPR, give oxygen, establish our airway, okay, ventilations, monitor and defibrillator. Make sure we attach the monitor and defibrillator, okay? Now, once we can see the rhythm on the monitor, is the rhythm shockable? If it is shockable, we go here. If it's not shockable, we go here. How do we know it's shockable? Well, here's the deal. When we're in cardiac arrest, there is only 4 rhythms that we can be in. First is pulseless ventricular tachycardia. Second is ventricular fibrillation. Those 2 rhythms are indeed shockable by a defibrillation. Asystole and PEA, pulseless electrical activity, which basically means asystole is flatline, there's no rhythm at all, no electrical activity. Pulseless electrical activity means the patient has no mechanical pulse, so the heart isn't pumping, but there's still some sort of electrical activity going on. We're more on that in a bit, okay? But we can't shock that, so it goes over here in the no category. So first, let's start with, we go with this patient, unresponsive, not breathing, no pulse. We did CPR, establishing oxygen, airway, monitor, defibrillator attached. We see they're in VT or VS, either one. First thing we do immediately is go ahead and shock. Why is that? Why? Why is it set up like this? Because there's 2 main things that will improve the outcome in a cardiac arrest. One is early compressions. The second is early defibrillation. Notice early compressions, early defibrillation, right? So in a way, we're kind of hoping that the patient is in one of these 2 rhythms versus one of these 2. Because from the science shows, this can help solve this, which then causes ROSC, return of spontaneous circulation, for them to get a pulse back. Where this could be, and usually is, more of a sinister pathway with less likely to get ROSC. Okay, not impossible, just less likely, okay? Because there's less things to do, all right? Now, we're gonna pretend for this algorithm that we just stay over here. I'm taking you all the way down. So let's say you're in a cardiac arrest and they're gonna stay in VT or VF throughout this cardiac arrest. So here's what we do. We shock the patient, okay? Immediately after we shock, the compressor's hands are hovering over the chest, shock, okay, right back in the chest, making sure our interruptions are less than 10 seconds with compressions for all this, okay? CPR 2-minute cycles, establish IVIO access, okay? That's our 2 minutes. Then we come down here. We're gonna go ahead and shock the patient again as long as they are in VT or VS. Now, if they're not at this point, we're gonna go over there, okay? But for this scenario, we're gonna say they're still in, let's say they're still in VF, right? Go ahead and shock again. Now we're down to this little bubble. Here we go. CPR 2 minutes. Epinephrine time every 3 to 5 minutes. That's why we started our IVIO. Then consider our advanced airway with end-tidal CO2 to confirm our advanced airway placement, okay? That's our 2-minute cycle. Now, we come to another rhythm check, okay? Making sure interruptions are less than 10 seconds. Is it shockable? We're gonna say, yes, it is. We're still in VS. Here we go again. So now in this 2-minute cycle, CPR 2 minutes, amiodarone or lidocaine can be given, and more on the drugs and doses in a little bit. And then we come to treat reversible causes, which are called the H's and T's of ACLS care, and more on that in a little bit, okay? So we have all that squared away. Now, where do we go from here? Well, what if we're working this cardiac arrest, and from the very beginning, the rhythm wasn't shockable? We start off in PA or asystole. Or what if we were over here, but then they end up in PEA or asystole on one of these rhythm checks? We don't continue down because we can't shock. We go right to here, okay? Remember, we cannot shock asystole. We cannot shock PEA on a rhythm check. So we gotta move over here, which is the no side, don't shock, okay? So what do? Let's restart the whole scenario. We go to our patient, unresponsive, they're not breathing, no pulse, rhythm check. Let's say it's asystole. Here's what we do. The goal is to give epinephrine ASAP as soon as possible. That's the goal to put in your head. So what do? Well, okay, we checked, it's asystole, okay. Hovering over, okay. Continue compressions, CPR 2-minute cycles. And in that 2 minutes, we're gonna try and do a lot of things if we're able to. Hopefully we have enough team members. We're going to CPR 2 minutes, IVIO access. We can consider an advanced airway. We don't have to do it, but we consider it. Same one over here. We don't have to do it right here. We're considering it, okay? A key note, I did not mention the advanced airway being, based on the science, the most important thing. It's great to do, we should do it, but it's not the most important thing to move the needle in getting ROS back. But we're gonna do it eventually, right? Okay, this is why it's set up this way. So if we have time, we'll do it now. Okay, advanced airway with end tidal. And then remember, when we're giving epinephrine, we're gonna give the epinephrine right here as well, okay? It's a lot in this first bubble, right? Epinephrine every 3 to 5 minutes, okay? Trying to really combat that asystole. Well, now we come to a rhythm check after the 2 minutes, and let's say there's still an asystole. What do? CPR 2-minute cycles and treat the reversible causes, which are H and T's. So that is what we have for ACLS algorithm. Now we talked about this. What is the most important thing? Compressions, and if we can do it, defibrillation. Here is our high quality CPR. Let's talk about a few things here. Now first, push hard and fast. So our compression rate is between 100 and 120 per minute. And we want to allow the chest to have that full chest recoil, okay? Now, some other pearls I didn't write down here. As far as ventilations, we don't want any excessive ventilations, right? So follow the guidance. More on that in a second. The second thing that I also want to touch on, not written down here, is how deep or how shallow you're going with compressions. So remember, with the adult patient, we want at least minimum 2 inches deep. That is our goal, at least a minimum for CPR quality, all right? Now, we also want to minimize interruptions with compressions. I've talked about that before in this video. Our goal is to limit it down to a minimum of 10 seconds or less. Now, here is where I'm going to come down here on that subject. Let's talk about the advanced airway, which is all the way down here, okay? With the advanced airway, now we know what I talked to you about earlier. We don't just jump on an advanced airway because there's other important things to do first. But what is one perk of having the advanced airway in place? Once we get an advanced airway in place, compressions are continuous. So versus with BLS, it's 30 compressions, and then we gotta do 2 ventilations, and we have the interruption there. That's not great, right? So if the science is telling us don't interrupt, why are we interrupting? Good question, right? So that tells me, because what I'm seeing from ACLS, I would love to get, as a paramedic I get seen, I would like to get an advanced airway in following the algorithm as soon as I possibly can, so then I can have continuous compressions. Pretty cool? Okay, great. So next piece here is change the compressor every 2 minutes. And I underline something important for my team leaders, my CPR coaches out there. Do not be afraid to tell another provider, hey, your compressions are getting a little fatigued. Let's switch, okay? If someone's fatigued and not giving quality compressions, then the patient's heart literally is going to suffer, okay? So it comes down here. Use the end tidal CO2 as your guide of quality compressions. So you have this as your guide, as well as your eyes looking at the person who also appears tired, okay? But you have this as a guide as well, okay? And we talked about this. We do 30 compressions, 2 ventilations until the advanced airway is placed, then continuous. That was the big pearl on this. And then I'll read the final piece off to you here. The advanced airway can be a supraglottic airway, or it could be an endotracheal intubation. Of course, if we can get an actual intubation, fantastic. There's a lot of great tools to help you do that. But if you can't, don't be afraid to use a supraglottic airway, like an iGel or a combi tube or a King LT or an LMA. List goes on and on. But don't be afraid to do that, because then we get the most important thing, we can get continuous. So this is our high quality CPR pearls. In our algorithm, we mentioned 3 main drugs: epinephrine, amiodarone, or lidocaine. So let's talk about that. Now, I keep saying the or to remind you, when you have VT or VF, you have an option, you have a choice. Do you want to use amiodarone? Do you want to use lidocaine? So I want to make that clear by keep saying or to not confuse you, right? So now every patient in cardiac arrest, whether you're on the yes shock or the no shock side, you're going to get epinephrine. And you're going to get epinephrine 1 milligram every 3 to 5 minutes, either IV or IO, depending on the access you established, okay? Now, when we're on the yes shock side, okay? So we're shocking the patient. They're in pulseless VT or VF. We have a decision. Do we want to use amiodarone or lidocaine? This decision really is not that big of a deal. They both do the same thing. The difference is, what drug do you have available? That's actually the biggest determining factor, okay? So amiodarone, IVIO, our first dose is 300 milligrams. Our second dose, later on down the algorithm, later on as we do 2-minute cycles, we come up, oh, I have a chance to give you amiodarone. Well, they're still there. What can I give? 150 milligrams, okay? Same with lidocaine. The first time we have an option to use in the algorithm, it's 1 to 1.5 milligrams per kilogram. And then we do 2-minute cycle, we have another chance to, they're still in VT or VF. Second dose, 0.5 to 0.75 milligrams per kilogram of body weight, okay? So now, these are the drugs. And one quick pearl, why are we giving amiodarone and lidocaine on the shockable side, but we don't give it on the not shockable side? These 2 drugs are medications that the goal of them is to convert the rhythm, right? So the goal of these medications is to convert the patient out of VT, convert them out of VF. This would do nothing for asystole or PEA because there's nothing going on. And that's why it's on this side. So we're gonna have a little fun here and go over the H's and T's. And you see I left some of these blank to explain how we're actually gonna treat these H's and T's. So let's go over this. First, what exactly are the H's and T's? The H's and T's are the reversible causes, meaning it's something we can do to get the patient out of cardiac arrest. So for example, let's say that hypovolemia caused the arrest. Well, if we give fluids, blood to the patient, if they lost it and they need it, that could get them possibly out of cardiac arrest. And we notice that down the algorithm, we find the H's and T's. So there's a list of H's and then T's, okay? So what does this mean? When we're nearing the end of the cardiac arrest, we've done so many things. That is where it's time to say, hey, let's just go over all H's and T's. Okay, hypovolemia, hypoxia, and then continue on, right? So the next one, hypovolemia, is, lack of volume. So fluid, blood will solve that. Hypoxia, what's that? Well, we need oxygen. Now we're kind of already doing that, right? We're giving oxygen, but that's how we solve hypoxia. They need oxygen, right? So next here is hydrogen ion acidosis. So the patient's in an acidosis, hydrogen ion acidosis. Well, what solves that? What med could solve that? Well, that's sodium bicarb, okay? All right. Next here is hypo, not enough, or hyper, too much, kalemia. What's our K? That's potassium. So too little or too much potassium, right? Now, if we have too little potassium, we got to give some potassium. If we have too much potassium, we give calcium, right? Then again, these are the first starting treatments, okay? Hypothermia, they're cold. They got to get warmed up. So warm up the patient, okay? Hypothermia, okay? If we're considering this as an actual H&T, and we're really concerned that hypothermia is one of the reversible causes, okay? And before we move on to T's, remember, we're not jumping on the H's and T's. We have way more important things to do first. This is nearing the end of the arrest. Let's say you work somebody on scene. Let's say it's been 15, 16, 17, 18, 19 minutes. By that point, we're down our H's and T's, and we're starting to go through them, okay? Now, T side, what's toxins? Well, any sort of overdose of a drug or poison. So I'm just going to put here OD, okay, overdose, okay? So we want to consider, is there something that we can give for a possible overdose? May it be anything, an opiate, a benzo, a poison. Is there any information we gathered on this? That's toxins. Pneumothorax. You may have heard in class, when we have a pre-hospital, okay, EMS, traumatic cardiac arrest, we're not going to call that code until we put 2 needles in the patient. Well, what does that mean? What that means is tension pneumothorax could be a reversible cause. It means needle decompression, okay? So that's something to consider, especially with trauma, right? Cardiac tamponade. Now, how are we going to solve that out in the field? We're not, okay? Now, you may have heard of pericardiocentesis, which is sticking a needle in the patient's chest, drawing out from the pericardial sac all that fluid, and now things are a lot better. That's not happening in most EMS agencies. If you're an EMS agency that does a pericardiocentesis, drop in the comments. Love to hear about it, okay? But this is going to be solved in hospital. So I'm just going to put in hospital. Now our final 2 are under the T of thrombosis. So thrombosis pulmonary, thrombosis cardiac. What does that actually mean? Well, that means we have either a pulmonary embolism, okay, a lung attack, or a myocardial infarction, which is a heart attack, okay? So either way, we're either robbing the lung tissue of everything it needs to work, or robbing the heart muscle of everything it needs to work. That's what's occurring here, right? Now, how do we solve a PE? Well, if someone's awake and obviously they got a PE, right? Thinking about heparin, stuff like that. So depending on what's going on with the patient. But again, both these things, ultimately, we're going to solve them. They're all going to be solved in the hospital. But now, what is one thing that we think about? This is the H&Ts. H&Ts are done when the patient is still in cardiac arrest. Now, one pearl I want to give you about myocardial infarction, without going too far into ROSC. When we actually are down and we're doing H&Ts, 2 things that aren't on here. If we get ROSC, we obviously want to do a 12-lead EKG to look for this. The other thing that's not on here, it used to be on here years ago when I first went paramedic, was checking a blood glucose. which is hypo or hyperglycemia. Is it gonna hurt to prick someone's finger and get a blood glucose? No, it's not. Not on here as one of them, but that would be my last thing I'll tell you. By clicking in the first link in the description, you get lifetime access to my Video Vault program. The Video Vault includes over 480 videos of content and now holds over 2,000 National Registry practice test questions. Also includes some really awesome bonuses like worksheets, drug cards that are pre-filled out all for you, community group access to ask me questions, and audio files when you are on the go. The Video Vault will find you no matter where you're at, whether you're an EMR, EMT, advanced EMT, or paramedic student, and my students use this whether you are getting ready for school, in school right now, or getting ready to go pass your National Registry exams. So click the first link in the description right now and get yourself lifetime access to the Video Vault today. I'll see you there.